Great, thanks, David. Can everybody hear me okay? Yeah? Excellent. So what I wanted to do is an introductory talk to talk about clinical decision support, how it can be used, and how it's moving and getting more sophisticated over time as well, with what we can do with it, both within a provider setting but also at a population level as well. I'm a doctor by background. I lead Cerner's advisory practice focusing on population health, but all our clinical performance improvement work as well. Great. So as we all know, we're all humans practicing medicine, writing software and so on, and to err is human, and we know this. It's very easy for us to introduce mistakes, and we spend a lot of time with our processes and our training trying to overcome this, but it does happen. And the same is true in the IT software industry as well. We need to run risk management processes so that we're not introducing new errors in as we go in the process. So this is one of the big challenge areas why technology can help try and support and overcome some of the challenges we have just as social beings. I think the second big challenge in this area is the time it takes for us to get the evidence base into practice. So I think a number of us will already know this sort of statistic, and I hope it's getting better, but I haven't seen anything more recent, that is taking us up to 17 years to get the new evidence base that we learn from trials and publications into common practice where the majority of people are using it. And that's a real challenge as well, and again, a real good opportunity for how technology can be used to try and accelerate that adoption life cycle to get new knowledge into systems. I quite like this statistic, but there's other ones out there where when you finish medical school, if you knew everything at that stage and you were reading 2 articles every single night and retaining them, at the end of the first year, you're already 1,225 years behind. We can't hold all of that information in our heads, even when we're super specialized. So I think it's a real challenge. And I think then when you put together these two things, that it's challenging for us as individuals because we can err, and it's taking us a long time to get the best evidence base in practice, there's a real good case for how can we do this better and how can technology help support this. So I just want to talk about a bit of the approach that we take in Cerner generically to get the evidence base into practice. I'll then come and talk about some practical examples of what we've done to try and accelerate this cycle. So we start with the evidence base, and we work with a number of our partners to do that. And we help them build that evidence base of knowledge into workflows and processes. And I'll again give some examples on this. And then we develop it into the systems, deliver it, make it available to healthcare professionals. But I think what's important is that we don't stop there, because I think the challenge with that, of course, is that you're still implementing information that's been knowledge that's been acquired some time ago, but also with the power of the data that's in the system, we've got the opportunity to learn how those evidence-based algorithms and knowledge actually play out in practice. And it may or may not be what you predict it to be, but we've got the opportunity to tweak and improve, and I'll give a good example around this later on sepsis, so that we can then get into a real-time feedback and then accelerate this academic cycle of getting best practice into practice. So this is quite a basic diagram. We're going to step us through this journey on clinical decision support upwards, talking about some of the established basic standard clinical decision support that's implemented within electronic systems around documentation, basic care plans, etc., to make little point decisions. Through more advanced, we're starting to get into workflows and care planning and how does decision support help that. All the way through to what we can now start doing, which is actually predict patient behaviors, predict what pathways might be appropriate for them, trended over time and so on. So I'm going to give some examples and build a story from top to bottom, from bottom to top. So first of all, I want to talk about passive decision support. So here's an example where we're making a prescription of warfarin within the system, but we've also put alongside that what the latest blood tests are for INR and PT, etc., which are the blood tests you need to make decisions on what warfarin doses are required. So this is a very basic example of passive decision support where we're bringing information together so there's context to enable clinicians to make better decisions on the spot. Very, very basic. So this is like a next level on. So what we're showing here is this is an action set that's actually been created by the BMJ. It's one of the BMJ's action sets. They've created a whole catalogue of evidence-based order sets. So order sets are when clinicians need to have a condition that they're evaluating the patient against, and they have multiple blood tests and radiology examinations and things they need to do. The order sets are a compilation of all those tests and things the clinician might want to carry out, but they've been constructed against the evidence base rather than just clinicians deciding what their own order set is and the things they need in it, or even an institution, a care provider. So these things have been validated against the evidence base about whether you need to do these things and do you need to do them at that point in the journey. What you can see here, but probably very difficult from the back, is the little hover text here over one of those items is showing how you can get to the underlying evidence base for why that item's there in the first place. So as a clinician, it's doing quite a lot for me because it's helping to bring this stuff together. I can still make my own decisions about what I actually do or don't do, but I can then, if I'm not quite sure or understand why we're doing this, I can get to it. I can click on that and get to the evidence base, and that will tell me why. And in fact, now I think with the BMJ, they're starting to link that through to your learning portfolio, because you might say, oh, that's interesting, I didn't know about that, I need to learn more about it, tick a box and I'll come back to it later. So we can start to get quite intelligent about how we do this passive decision support. So this is a good example about embedding knowledge into workflow. Good. And this kind of makes the case of why that's important. So this study here showed that 75% of decision support interventions succeed when the information is provided to clinicians automatically, whereas they don't succeed if clinicians are required to go out and seek that information, which is a real challenge. And I think what's quite interesting here is, as you look up these odds ratios, which is the likelihood of this having a positive effect, you can see how it moves quite dramatically from just computer-based generation of decision support through provision of recommendation rather than just doing an assessment, to providing decision support at the time required and the location that you require it, now starting to come up. But then when you get to that automatic provision of decision support actually embedded as part of the workflow in the normal way clinicians work, a massive increase in the effectiveness of how that decision support can work. Next up, we can then start getting a little bit more sophisticated because we can then start making it more dynamic. So within all the patient record systems, the clinicians are capturing information about the patient, and this information can keep changing over time, and with the right business logic and rules behind it, can then start triggering things. So in this case, the information that was behind there has triggered an alert, like an early medical warning, that can go out to the clinical team so they can then start taking action on it. What do I need to do for this patient because there's a challenge here? So now starting to get into much more active decision support, where it's sort of prompting the clinician and helping them to see patterns of data and what to do about it. So next, moving on from that, we can do not just sort of triggers for alerts, so to be aware of, but we can start using it to drive suggested plans of care as well. So here we can see a falls risk assessment with various parameters that have been filled in around their risk, and that can trigger notification messages about what their overall score is and what needs to be done, but that can then trigger and recommend particular pathways for how to manage that. So the example here around fall prevention and management with the different care plan activities you can now carry out to try and reduce that fall. So in the last example, we were seeing how data can trigger just alerts. Here we're seeing how it can then make recommendations for care plans. And we had an example of a care plan before for acute exacerbation of asthma. You can see how these then can then start coupling together. So I just want to talk about how do you get this in practice? A little mini example with venous thromboembolism, because it's not just a matter of applying the business logic rules and putting them in the applications. There's still all the people change, culture change aspects of it to work through as well. And in some cases, the learning that you need to have within the organization of what works and doesn't and how you tweak it. So with VTE, we do various things to make sure the rules are in the system. There's an advisor tool that looks at the data and prompts on the right things to do, and there's reports you can run and so on. So there's quite a lot behind the scenes. But when you've got it working in practice, this is what I wanted to show you. This is showing VTE rates per 1,000 patients. The baselines here across on the left-hand side for when these processes for decision support were put into place. But what I want to show is that over time you can see the interventions are reaching some tipping point on the cumulative curve, and then you can see the overall rates for coming down over time and the impact of the interventions. But I think what's quite interesting is that the way they did it in this particular facility is they started with all the nursing content for VTE assessments and prevention, and then the rates in the 4-month rolling average started to come down. As the next phase of the project, they introduced the VT Advisor. So the VT Advisor is more sophisticated than just making sure you've done the assessment for VTE. It's then taking in the information from the hospital, the community setting, to make sure the clinician, the doctor, can make the appropriate decisions for patients to help avoid venous thromboembolism. So they started with the nurses and then they worked with the clinicians. And with the doctors, what they found in practice is they found a way around the system. They found a way not to do it. So actually what started to happen, which is quite interesting, is the rates for VTE then started to get worse again. So when this was understood and evaluated, they then changed the system and came out with a notification flag as well, retrained and re-educated, and then the rates started coming down again, and it's got quite low. So I just wanted to use it as a practical example of when you're trying to do this stuff, you've still got to work with those clinician groups, understand how they use the systems, how do those decision support rules actually get used in practice or not. And sometimes the learning can be quite simple, because clinicians, you need to have the ability to be able to say, I'm not going to do that, and give a reason. But if it's not very intuitive and it's flagging them all the time, they're going to get pretty fed up with that. And they're just going to tick the top box. So you never really understand what's going on. So this is Glastonbury and the number of people there. The reason I'm showing it is this is roughly the population of people in the US that are killed by sepsis every year. It's a big number. There's a lot of people, and a lot of it is quite addressable by support with clinical decision support. This is Wolverhampton Stadium, smaller, but it's roughly equivalent, if not maybe it's larger than this for the number of people that we're killing in the UK market with sepsis. So it's quite a big challenge for us with sepsis, and I want to use it now as an example about how we iterate our algorithms and use the technology to try and get practice out much faster. So big challenge for sepsis in terms of the cost to us. Time in ICU, longer admissions in hospital as a result. It is a challenge because it can be quite difficult to diagnose. Early detection's really important here because you've got a 6-hour golden window to do something for patients before the mortality rates just massively increase. Really important as we're automating hospital environments because if you're putting in clinical documentation for nurses to record their observation data, what you don't want them to do then is to sort of hold that information back, and at the end of the shift, their workflow is to put all the information in the system at that point in time, because what you're going to do is miss your window of opportunity with sepsis. So there's practical aspects to it. So we need alerts and decision support to try and help us identify patients that are at risk of sepsis. And it's largely preventable if we can catch it early. So the work we did in Cerner on this is we took the existing evidence base for sepsis algorithms, things you look out for, and we built that into a prototype in a system and ran it in parallel to the day-to-day working. What we found in practice that it was triggering alerts 35% of the time. Now, that's a huge amount of alerts to be generating, and the clinicians won't have the time really to go and necessarily evaluate all of those individuals. And the sensitivity and the specificity rates were very high. They're in the upper 70s, so that was fairly good. But the challenge on us was actually, how do you implement this in practice so that we're not triggering 35% of the time? What can we do to try and improve the algorithm and the decision support and how it's working with patients? So what we did is we went into a lot of our US client base, and we have now done this in Spain and other places as well, and we found 68,000 patients that had died of sepsis, and we put that met the research program we're doing. We put them all together in a study where we used technology, including simulation modeling, and to work out actually what are the factors, what are the data elements within the system and the parts of the algorithm that were really contributing a lot to the sepsis algorithm alerting, and what were the things missing that were actually contributing as well. So lots of regression analysis, lots of simulation modeling as well to try and tweak the algorithms. So we went through a cycle of this where we were doing a literature review, simulating the algorithm, analysing the data, piloting in practice, checking against the medical notes and what actually happened, discovering where the challenges were, and then iterating and changing the algorithm. So we've done this now. We're up to the 13th iteration of this algorithm. But what we've managed to do is keep the sensitivity and the specificity pretty much as high as it was before, but we've managed to reduce the alerting rate down to 15%. So it looks a little bit like this in terms of your true positives and negatives, etc. But this has come up with a negative predictive value of 0.98. So it's very, very good at not making a mistake when we predict that it's a negative value. But it is triggering, so it's triggering at this sort of 70% level for identifying sepsis cases. But it's also triggering, not 35%, but it's triggering this 15% here. But what we found was when we looked at these patients, they were pretty crook and unwell anyway, and they did warrant the special attention. And as this is saying, the ones that were alerted 10 times more likely to have a diagnosis of sepsis and 30 times more likely to die in hospital. So where we ended up with was with the new algorithm on its 13th iteration, and we've been able to do this over a period of months rather than years, sending alerts, and it's had quite a good impact on different providers out there. So for Trinity Health, we've managed to reduce the sepsis mortality rate from 15 to 12%, septic shock cases reduced by 12%, and we've had an impact on the length of stay as well. And we'll be able to measure the number of lives saved as a result of that. I think it's quite a nice example because I think there's a debate about whether sepsis will be a sequin next year. But I think in terms of where this is going in the future, the way we've built this is actually to do the algorithm in a cloud that's agnostic of the patient record system, because what that gives us the ability to do then is take data from different sites and different locations. And you can well imagine for sepsis how you've got some observation data, you've got some pathology data, there's lots of different bits of data that contribute to the algorithm. So if we can do it in this way, we can then take data right across a community as well as a hospital provider, do the algorithm and send the alerting down into the systems. And so for us in Cerner, it's a really good journey towards population health management. So all our new algorithms for decision support, where possible, we're starting to build into our cloud architecture now, because that gives us the ability to take it from any particular system, crunch it centrally, and then drive the alerts out. And then what we're working on now with a lot of the accountable care organizations in the US market, and hoping to do here, is making sure you can then run programs for diabetes, people at risk of readmission, whatever your cohorts are, but then have the workflow come back to the individuals working in the different settings across the population. So just in summary, what we're trying to get to with clinical decision support and improving clinical performance is finding ways of better embedding best practice and iterating and evolving it. Finding ways of capturing core quality measures like we have a Sequin in this country, but not with nurses running around with clipboards once a month to collect the data, but building it into the workflow so it happens as a normal course of their work and activity. Then establishing clinical performance improvement programs because the falls aren't what we want them to be or the pressure ulcers aren't, and then driving those out as change programs. And then with the opportunity to say, well, actually, we're trying to manage this across the whole population. How do we do it at a population level? I think in this country, in the UK, we're just now starting to get there because there's certainly the stimulus with the £260 million fund to do more clinical functionality, which is great. But we're now just starting to see a lot of the hospital providers introducing clinical documentation into the patient record systems. But once you start doing the clinical documentation, you've got all the ability then to start working on clinical decision support and looking at performance improvement projects to drive better care out of that. And you can just see here, for some we've managed to reduce falls by 28%, pressure ulcers by 48%, and so on. So hopefully then I've managed to take you through a little bit of a journey on clinical decision support to show you how you can make it work basically by basic triggers in a passive way, all the way through to active driving out care plans for patients, and then hopefully one day working much more at a population level. Thank you.
Thank you, Justin. Now, that sounds fantastic because some of our clinical outcomes in the UK do lag behind other countries. And as commissioner or provider, this seems to be stuff that we need to be looking at. Any comments or questions? There's a gentleman at the back there.
Hello, Clive Stringer from King's in London. Are you publishing the algorithm for the sepsis?
So the sepsis we're making available to everyone. Some of the publications are being written up now for these studies. Some of the algorithms we've been working on with customers, they want to make freely available to people, so we've been doing them in partnership with organizations. In other cases, actually, they want to, in the US particularly, sell the algorithms as their property. My view on the NHS market is because of the NHS and the opportunity, hopefully there'll be a lot more sharing of some of those algorithms. Sepsis, we're making available certainly to our customers, and then we work with them if they want to improve it or things are slightly differently here. But yes, we're hoping to publish an amount of this. We've got some publications being written now.
Robert Trahan-Jones from INR Star. As you know, a lot of decision support software, particularly when it makes recommendations for changes in medication, is classified under European law as a medical device and has to go through a lot of additional regulatory material to make sure it satisfies that accreditation process. Is that simply a legal nicety, do you think, or should that be of real concern to commissioners and clinicians?
I think it's a big challenge here with the changes to the Medical Device Directive and how much of this stuff is really captured or not captured. Certainly the EU put out some guidance last year, and each country, of course, can make its own interpretation on these things as well. The general view with the MHRA here has been on the side of if the software is making a decision without a clinician, then it should really be captured like that and it's behaving like a medical device. Whereas if it's supportive information but the clinician's making the end decision, then perhaps not. So I think for software vendors, we're kind of grappling with the grey area space of where does it sit between that. And certainly some of our solutions are medical devices, and we do that in Cerner. Our FarmNet is going through the process to be CE marked for pharmacy. And we have drugs trolleys that spit out medications that are a medical device, the trolley itself. So we've been doing it in certain areas. This area, we're still doing some of the evaluation with countries about whether this is entirely captured or not. I think generally it is a bit of a grey area, I think, in decision support, where some of the stuff I'm showing you, particularly towards the advanced end, about how much really the clinician is in, well, they are in control there. They're still making the decisions, and I think that's where we've tended to stop in this space. But you can imagine things like in the debate in the UK was things like flu line, where there's an algorithm that runs that determines whether you get the prophylaxis or not. You've got an algorithm that's really making a clinical decision because people would then be excluded and others wouldn't be. I think that was determined that it would be caught by a medical device type category, but then they put it on hold because of the greater public good of getting the algorithm out there. So I think a lot of it's still to play through in the market. Vendors will be watching and trying to work out what to do with this and how far to go. And as a global vendor, it's challenging just because every European country could take a different view on this. So definitely a challenging area. So yes, some of it will be captured at the end, I'm pretty sure.
Because 111 has a similar issue, isn't it, of giving clinical advice through algorithms often done by non-clinicians is a real issue. Yeah. Anybody else? Gentleman here. I've got you running around here, sorry.
Hi, Justin. Thanks for the quite an informative session. I wanted to know, in scenarios where you have several different clinical applications which are used, and each one having their own, database, for example, in such a scenario, how do you see we could, utilize this concept of automated decision making, and what would be the risks associated with this?
Yeah. So I touched on it a little bit with the approach we were taking here, because this approach for all the new stuff we're doing, and it's actually, these are all running on different applications. Actually, even within a hospital environment, they have 400 applications. So, but they could, one of the challenges we have in this space, to your risk point, is that the information models can look very different in all the different information systems. Our first step here, and the way we're doing this to create longitudinal records, is to map the ontologies between this, so that we can then bring together to run the algorithm on SNOMED terminologies. So they're mapping these to it and trying to put a self-learning system in. As clinicians make associations, they get stronger. There is some work going on in some European countries that are using the OpenAir Foundation's information architecture. At the moment, it works very well when you've got these are on OpenAir instances as well. But they've managed to then get to a state where they've got reuse of clinical modules of information. So if you can standardize how you do blood pressure with all its metadata and hemoglobin and A1C and all its metadata, then you should be able to reuse those components and write standardized queries against them, and then port those queries around so others can use it as well. And hopefully in time, that sort of methodology will get more adopted, because I think it gets to a space where you can execute a guideline using technology. One of the problems we've got today is that when us as technology vendors try and implement guidelines produced by NICE or other bodies in other countries, they don't tend to be written to be executable in technology ways. So you end up with impossibility loops and all sorts of things, or woolliness, and you're not quite sure how to put it in decision support. I'd like to see a time, but I think it's going to take a while to get the maturity in the marketplace where we can have guidelines for how to write guidelines so that they are technically deliverable. So I think a lot of this can be solved with ontology, mappings that give you sort of more of a longitudinal record to run your algorithm on. But I think in time that won't be enough. We'll have to move to actually a proper clinical model, and there's definitely work going on between the US and EU to try and build those clinical model templates. I think what they learned was expecting everyone mapping to each other to solve this isn't going to work. They're looking at what's the template everybody can map to and out of. It's a very complicated informatics area, but you've got to kind of get started adding value to try and change things.
Well, thank you, Justin. That's absolutely brilliant. And thank you for your questions. For those who are about to leave to go to another session, remember evaluation forms, enter the competition, and so thank you once again. Thank you very much. Very well. Matthew was trying to arrange a meeting, but he keeps having problems. This has nothing to do with you. This is Matthew. But of course, he'll be pushing up soon, as you say. So I'm fine, thanks.
Nice to see you.
Yeah, same here. Except when it said Cerner, I was like interested. Because I couldn't see out there, you know.
Last week.
So at least I know somebody. Yeah. Do you have a stand here, by the way? No. Yeah. Okay. All the best. Ready to go? Yeah. Well, welcome to this next session. There doesn't seem to be much movement in the audience, so I probably don't have to go through everything about mobile